hopefully we'll have a few more stragglers, or otherwise, please emphasize the utility of this to your faculty so that when we have future ones of these, we get better attendance. So I'd like to introduce Dr. Al. We've been practicing this. If I was Polish, I would try and say Kasprowicz.
Kasprowicz.
Yeah. Okay, but I'm not. So I'm sort of Philadelphian, actually. And he is on the faculty in the Department of Behavioral Medicine and Psychiatry. He is an MD. And he is also director of the Carruth Center here at WVU. The Carruth Center provides comprehensive counseling services for students, and he'll talk about those services. They are both for undergraduates and graduate students, and the Carruth Center is over near the rec center, for those who have never noticed where it happens to be. So Al has been really a great help to me as I've dealt with more than my personal preparation for student issues, and we want to educate you so that you know some of the things that you can and should do when some of these issues arise, or where to get help. So with that, Laura, you wanted to say a few words?
Very few. Thank you for coming. And thanks, Lisa and Nicole, for putting this together. We've talked in the basic science chair meetings a few times in different settings that all of us are landing more often in circumstances that we don't quite feel completely trained to manage. And when that happens with me, I'm like, well, let me find Dr. Solani. But it feels,
I'll call Al.
Yeah, it feels more and more frequent that our students are dealing with challenges that aren't quite like when we mentored maybe 10 years ago. It's just a different day. And so I appreciate that people are willing to kind of expand our skill set as mentors and as leaders, and we appreciate the partnership and helping us with that. So welcome, and thanks for coming.
Thank you very much, Lori. And Lisa, thank you for the introduction, and Nicole for the arrangements. Lisa, if there's only one thing I'd change, lest I offend my physician colleagues, I'm a PhD in clinical psychology. I've been with the Carruth Center for about, this is my 9th year. I've previously been in private practice in Kingwood, West Virginia, which is where I live. And previous to that, I had been on faculty with behavioral medicine. I continued there as an adjunct physician. But what I want to share with you, as Lisa mentioned, is a very brief overview of the types of services offered at the Carruth Center. It's always best to start there because there are a lot of myths and misconceptions, even in terms of where we're located. So I'll try to go through that relatively quickly, but it'll give you an idea of the types of services that we provide. And then Nicole had also given me a list of questions that I believe that Lisa, you had fielded from your colleagues over the last several months, and I'll try to drill down and answer those more specifically. As well as towards the end of our presentation, I'm going to emphasize the component that we most frequently address with our RAs, our employees and staff on campus, and that is how they might handle or address situations where they're working with disturbed or distressed students. There are a couple of additional slides that I've tucked in today just to address some of the questions that came about. The first thing is to let folks know we are located at the Health and Education Building. For many people who have had historical relationships with the Carruth Center, many people still think of us as being downtown at the Student Services Center, but we moved out in 2014 to the Health and Education Building. We are on the same side of that building that Student Health and Urgent Care is in, and we often make a point of letting folks know that because the other side of the building, which is physically similar but not contiguous with our building, is the College of Physical Activity and Sports Sciences. And we have both staff and students and police officers coming in on the CPASS side and not being able to get over to where we are. So if you're among the frustrated when you do come to visit, you're in good company. So that red area is that part of the Health and Education Building where the services are located. We're up on the 2nd floor. Just the basics. It's surprising in some regards that both staff and sometimes students are not familiar with the fact that virtually in all psychological and psychiatric endeavors, the information that they provide to us as young adults is in fact confidential. We have a number of students that were in therapy since they were, let's say, 8 or 9 years old, and mom and dad were always a part of that. And so they assume that what they share with us, they're not sure whether it's going to stay in that room. Likewise, it may not surprise a number of you that on administrative matters, and matters that address academic standards and concerns, we have many colleagues who will call and say, did so-and-so show up today? Can you tell me what the nature of your interaction was? And we'll say, well, doctor, fill in the blank. As you know, our services are confidential. So it's one of the things that's really important to our clients, obviously. And whether they are involved in student conduct issues or academic concerns, even though there is an interest to know among their educators, we are held to a state and a federal standard and an ethical standard about maintaining confidentiality. We certainly can talk, and we'll go through a number of scenarios today where that confidentiality is in fact breached for issues of addressing imminent risk to self or others. We'll certainly talk about that. The services that we provide to our students, for the most part, are in fact free. For years, and this is true at most all student counseling services across the nation, there's only about 4% of student counseling services that actually bill for services. And that may change in years to come, but the student fee, which is an omnibus fee, is split out so that the majority of our services for individual and group therapy, for outreach activity, is in fact covered by the student fee. So even though since 2014 students have had that hard waiver, they all have mandatory insurance for the most part, we do not charge for our services. We are not looking at insurance reimbursement in that regard. That's our website location. That's our number. I'm going to tell you about why that's particularly important, because the next issue has to do with the after-hours phone. We have, in the time that I've always been there, we've had an after-hours phone. And in the last probably 7 years, we've contracted with a national company called Protocol, so that if any of you were to call and it was after business hours, so anytime after 4:45, you will be asked, do you want to speak with a counselor? And if you hit number 1, you are immediately connected with a counselor, but that counselor is not on site here. They are part of this national network known as Protocol. They will field all the relevant information. Since we have an account with them, they know exactly what services are available in the Morgantown area. And if that counselor, speaking with a staff member or a student, determines that we need to be directly involved, they will then contact our counselor on call, and we'll have boots on the ground. The number of calls that I've received at 2 o'clock in the morning from students who are intoxicated and wanting to know whether they have an appointment the next day is circumvented by this lovely service. But it also means that there are probably about 40 calls a year where we are contacted by Protocol because there is a more imminent safety concern. And it's important for our students and our staff or faculty to know that that Protocol service is available 24/7. It's not common, quite frankly, for a lot of other counseling centers to do what we do. We have extended hours, and Lisa knows very well, and others who have dealt with other administrators within health sciences make a very good argument, not only for an embedded counselor here, which we may talk about today, but also to have extended hours available, especially to our professional students. We have a large campus. Students' academic obligations often have them very busy during our regular business hours from like 8 in the morning till 5. And so Monday through Thursday, our return appointments will go as late as 8 o'clock. And that's really intended to help service our professional students. At the same time, we do something that behavioral medicine can't do, and or it's not really set up to do. We have drop-in hours. So essentially, a student could decide just on the spur of the moment that last night was incredibly chaotic, and whether they have concern for themselves or a roommate or whatever, they simply could drop in to our clinic anytime between essentially 8 and 4 o'clock and be seen by the next available counselor. It leverages a huge amount of resources to be available. We'll have 18 students. Earlier this week, we had an afternoon where all of our returns are coming in, but we had 18 new students come into our drop-in clinic. And their presentations could be everything from a psychotic break to a concern about a potentially failed relationship or test. There are no circumstances too large or too small to be staffed at our drop-in clinic. The one exception to that is if any of you are dealing with a situation where you know that the evidence before you, either verbally or what you've been told or what's appeared on social media, suggests that that individual is at imminent risk to harm themselves, please don't bring them to Carruth Center. Take them to the emergency department. And if they're reluctant to do so, absolutely call us and we'll help consult in those situations. But one of the things you'll hear me talk about today, and it's something that I think is the greatest burden for a lot of us who work in the mental health field, is well-intended friends, family, and staff members will be alerted to a situation that involves a certain level of risk, and they're concerned, but they take such a hands-off position that they simply want to get them to us as soon as they can, when in fact the better disposition would be to try to get the student to the emergency department. We'll talk about some of those scenarios as we go forward. But that's the only set of circumstances where, again, if you're involved with a situation that you're aware of or a staff member or colleague is familiar with, and it certainly appears to be an imminent risk situation, it's a public safety issue, both for the person of concern and whoever else may be involved, and literally should be coordinated with the ED and possibly university police to get that person immediate help. The types of services, obviously counseling. And the majority of students, would not surprise you, are interested more in individual counseling than in group. And we'll talk a little bit about the types of groups that we offer. And then there's a focus that we also have on substance abuse. A number of folks are familiar with the fact that SAP, the Student Assistance Program, is the acronym that's used to describe the services we provide that are psychoeducational for students who are cited on campus or off campus for drug and alcohol related problems. So they are not necessarily willingly participating, but because they've been sanctioned or they've been cited, they will come to our neck of the woods and receive very supportive but very intentional instruction and therapy with regard to their substance use. We have had psychiatry at the Carruth Center long before I got there as director, and all of our faculty are in fact from behavioral medicine. So we have 2 full-time psychiatrists and a couple of part-time psychiatrists as well. Access to psychiatric services at our facility is it's easier in some respects than it is in behavioral medicine. So we have urgent appointments for our students who need to be seen urgently, even if it's a psychiatric concern. MindFit, and I'll talk with you very briefly about this. There are a number of university counseling centers who really struggle with how they attend to or how they deal with issues associated with learning difficulties, especially when it comes to ADHD. There are all sorts of opinions that people have, some rightly held and others are kind of more fanciful. But there are concerns that this college campus has with the overprescription, the abuse or the misuse of stimulants. And so MindFit Clinic was set up years ago as a more objective way of screening and evaluating the attentional concerns of students. It won't surprise you to recognize that all things attentional are not ADHD. The number of students that present with concurrent sleep difficulties or anxiety will often affect memory and executive function and attentional difficulties. So MindFit was really set up as a way of being able to be more proactive in helping our students understand what's the nature of their problems, what might be available to them in terms of concurrent treatment approaches. And ours is the only center in this area that offers non-pharmacologic approaches to the treatment of ADHD. So we have procedures known as neurofeedback, cognitive enhancement, that are very sophisticated. And for those of you who are interested, I can talk with you more about that. But they're really intended to provide alternatives to psychopharm treatment. Yes?
If a student goes to MindFit
Yes.
Because they think they have a learning problem, is there any coordination between what happens there and the disability services that actually
Yes.
alerts?
No, that's a great question. In fact, that's one of the ones that Nicole had forwarded from the inquiry from your staff. There's actually great coordination. And one of the things I'll share with you, and this is often the way it is, there are a variety of areas in town in private practice as well as the MindFit Clinic where students can go to speak with a professional about those concerns, to consider whether some form of testing or evaluation should be conducted. But then here at the university, it will never be the provider who determines the accommodation. That information then is forwarded to another objective group, the Office of Accessibility Services, and they will work with the student then to determine what forms of accessibility or what forms of accommodation, should be extended to that individual. The Office of Accessibility Services then also has greater and more intimate familiarity with what classes present what type of challenges to those accommodations. And And so they are the ones who ultimately are working with that student and then their academic home program, their professors, their deans, to really craft that. And it's important that that level of objectivity remains. Outreach activity, essentially what I'm doing today, and which I really love doing, whether I'm talking to staff or students, we do a lot of outreach services, and then consultation. Lisa and I are intimately familiar with situations that arise, whether they are urgent or whether they're prevailing circumstances, and all of you have the same access to our counselors if there are problems that you're having, if there are classroom disruption, if you anticipate some challenges, either in terms of your instruction with your students, we're more than happy to consult. In fact, that's one of the things we would much rather do. We'd rather talk with you well in advance of an anticipated crisis. We'll also be there for you when it's going down in your classroom or in your hallway or in your office, but we would really love to be able to anticipate how best to approach conflicts that you might experience. And that again brings us to crisis management. I put this slide in here specifically today because one of the things that counseling centers, and ours is certainly included, are burdened to do, is to provide services outside of our center for the advancement of a student's enhancement academically or socially. We're burdened to do that because we are so understaffed that all of hands need to be on deck when we have 18 walk-ins. The number of folks that we're seeing for our psychiatric and psychological appointments mean that a lot of our staff really do not get out of the center. And so we work as effectively as we can to introduce these types of programs. So in the month of January, and this is really meant to target kind of the academic needs of a lot of students, we will set up a workshop series like this that are not intended for our Carruth clients only. In fact, they're advertised throughout the campus so that if students are having issues with regard to time management, about academic confidence, now that they've gone from being a very successful undergraduate student to a graduate program that is really kicking their butts, and they're realizing for the first time this is going to require a whole different approach to my academic rigor than what I've ever known, we set up these programs to let students know we're there for you. We can talk with you in a larger group about skills and teach you certain time management and study skills that, again, maybe you hadn't needed to use in earlier experiences. But this is something that I wanted to let you know that, again, we are dealing with students in crisis. We're dealing with students that come to our center for specific guidance and help, but we're also there to create, and if there are recommended courses that you would suggest that you would like to see us make available to your students, let us do so. We do them on relationship health. We do them on a whole variety of wellness topics, just again to try to allow our students to become more resilient. Going back to the individual and group counseling, our work is really intended to be short term. We see 1/10 of the student population here, and that might not seem like a lot, but we see over 3,000 students every year and close to around 16,000 appointments. And there simply is no way that we can offer long-term psychotherapy to 3,000 students. So we're not cutting anybody off at the knees. In fact, one of the things we do really, really well is we see all comers. And I was at a new student orientation a few days ago, and a mother came to me and she said, I just wanted to check with you on how I can get my daughter involved in services. She is diagnosed with bipolar affective disorder, and she's also on the spectrum. And she has a therapist that she sees usually once a week, and psychiatric support. And I said, this is great. I said, I really appreciate you being in contact with me. I said, what I would recommend is that you call and talk with one of our case managers. And if your daughter can do that on her behalf, we'd prefer that. And certainly you can come in and join her. But what I'd let you know off from the start is anybody who is doing well with that frequency of support will be better served by establishing a relationship in the community, which can be sustainable over the next 4 years, which can accommodate that frequency of service and that coordination of service, and that would be better suited to behavioral medicine at Chestnut Ridge or any of our group practices for individuals who specialize in that area. So one of the things we try to do is make sure that we can connect actively our students with the support either in the community or in our own house that would be best suited to them. Sometimes students simply don't understand why they can't be seen weekly for 52 weeks of the year. when we have a waiting list by the third week we're into classes. So we work from a brief treatment model. The number of sessions that most of our students attend is roughly 5. But we will have students where we are seeing them well beyond 12 sessions. We're seeing them for 20 sessions. If they start a relationship with us and that's what they need, that's what we'll give them. But if we know right out of the box that they'll need a more intensive form of care than something else or someone else in the community can provide, we feel that's our ethical responsibility to extend that. So that's one of the things that's important to know, that students who are seeking our services are introduced to a short or brief treatment frame. Groups vary from semester to semester, but this is an example of the types of groups that we offered last year. Very often we will always run a group for sexual assault survivors. We always run groups that deal with mood and anxiety disorders. Among the students that we will see, the 2 top forms of presentation are those that speak to depressive disorder and anxiety, but there are a lot of other groups that we run as interest is expressed. A graduate student support group would not surprise you that we see a lot of those, and especially among our international students. They really enjoy the benefit of being able to talk with other students. And our international students group is often dominated by graduate students. But that's just an example, and again, our groups are always free as well. Students are sometimes reluctant to join groups because they're thinking to themselves, yeah, the last thing I want to do is sit across from a stranger and talk about my difficulties. But without question, the most highly recommended interventions we have are groups, because they recognize, oh my gosh, I'm really not alone in this. And to be able to hear other people describe things that are similar to mine or enough different that I kind of took their lead and I decided to do this, with my relationship with my dad. It's just very powerful, as you might anticipate. So we always enjoy the reluctant students who really are advocates for group. MindFit, I'm not going to go in greater detail on that for now. Substance use resources. The 2 things I would want to share, I talked with you about the student assistance program, and yes, as you know, graduate students are also cited for infractions. But the real issue is not the undergraduates or the graduates that are cited for infractions. It's those who either recognize through that citation or recognize on their own that they have substance use difficulties. So I don't want to suggest to you that the Carruth Center is only the repository for psychoeducation about why you should or should not be using marijuana. Students who self-identify either come to us or refer to us for a whole variety of addiction issues, and we gladly welcome and see those individuals. We have folks who are trained specifically to help students deal with those concerns. On the right side of this ledger, I'm listing information about the Collegiate Recovery Program, which is relatively new. It's not run through the Carruth Center, but many of you are familiar with Kathy Ura, and she was my direct report when I first came here. And Kathy is now the director of the Collegiate Recovery Program. It's been up and running for about 2 years. This is the first year where they really had support in terms of the student community and alumni and faculty. But for those of you who are familiar, behind the towers, residence halls, there's like a 4 condominium suite that was once used for resident faculty leaders. And the Serenity Place is the name given to one of those condominiums that is the house for the Collegiate Recovery Program. They do a remarkable job. You can imagine that it's difficult for a student coming to a college such as ours, where, are we the number 1 or the number 3 party school this year? We have parents who love to send their kids here because we have that reputation. It always blows me away that we have parents, I want my son or daughter to go to them. Be that as it may, for people who are in recovery, this is a difficult community to live in. And so the support that is gathered from other students, both young and old, who are involved in an active recovery program is just, you can't overstate that value. And it's the type of thing, as Kathy continues with the program, we would love for faculty and staff or alumni who also identify with the benefit of their own recovery to become more involved as well. A lot of these students really do fear that there are no mentors older than themselves who have had some of these challenges. And even though they know different, to have that supported within the community would be just outstanding.
Al?
Yes?
Can we mandate that students attend one of those?
No. It really has to be self-selected. It would really be within the philosophy and the spirit of a recovery community that no one is there in a mandated or coercive fashion. It really has to be something that they elect to do.
Because you had mandated with an asterisk.
So that's on the student assistance
that's
program
right.
side. Yeah. And those individuals are referred to us from student conduct because they've been cited in the community for some form of alcohol infraction.
Oh, okay.
And but I'm glad you asked for that clarification. So yes, in terms of the student assistance program, the mandate only comes when it's associated with an infraction of the student code and it's coming out of student conduct. But that's a great question. I'm not going to show this to you necessarily. I told Nicole that it's a 90-second video that can be a little glitchy. I present this more to our students. Essentially, My Strength is a pilot program offered by Aetna Student Health. But it's a really neat way in which students can engage over 300 different exercises that stem a range of fields from alcohol abuse to dealing with the grief or the loss of a loved one to things that are more positive psychology around spirituality or humor. It's a way in which students can use their phone or their laptop at 2 o'clock on a Thursday morning when they're having a panic attack, log into this site and get some feedback on how to handle a panic attack. And if you're interested in My Strength in any way, and staff can sign up for it as well, please visit the Carruth website, and under resources you can get more of that information. This next segment is the segment I wanted to get to again, and we're going to go through it fairly quickly. I want to make sure you have the basis of the information. But as I was sharing with Lisa and Nicole and Lori too, my desire today is that we can talk about specific scenarios based upon the background information and based on your own experience, so we can talk about those before we get too far into the day. But these are common signs of distress in students. And again, none of these will surprise you, but sometimes interesting to kind of just remind yourself of the breadth of what can be demonstrated. Many of them overlap, but they're not necessarily also indicative of a student who is distressed unless it's markedly a change from their usual pattern of behavior. And that's one of the things you'll often hear from folks in the mental health field, is that when people are asking for signs and symptoms, although there are some prevailing states that sometimes indicate a difficulty, the real issue is whether you're observing a change. And for many of you as staff and faculty administrators, this will be borne out by your own experience. You'll have folks who have come to you and say, Lori, I'm dealing with this professor and their TA suggesting that this one student is now maintaining really poor hygiene. And that's really unique. And now we've seen the third absence in the last 2 months, and that's also really unusual for this individual. So typically, even in these areas of signs of distress, you're looking for a change in normal. Because you know that there are some students who are particularly more introverted. They don't necessarily kind of hang out with anybody. You don't know much about them other than the fact that they tend to be good students. And you can't automatically suggest that that student's withdrawn. They just may not be as interactive as others. But these are common signs from withdrawal to emotional overreaction, issues with carelessness, being able to disregard things that they are otherwise typically taking in pretty easily, concurrent alcohol and substance abuse where changes in that use are often a good indicator. Again, restlessness, distraction, poor abilities to concentrate, excessive worry and anxiety. This last area, poor contact with reality. Some of you will go your lifetime and never encounter somebody who's having a psychotic experience. Others of you will have family members with whom you've had experiences which display certain types of delusional behavior, especially if you're looking at Alzheimer's or different types of dementia. You'll see some of that available. What's interesting is that you're also working often with students who are at a time in their life where between, let's say, 17 and 22, if there's a family history of schizophrenia, you are more likely to see the manifestation of some of these symptoms even in a subdromal way in that late adolescent, early adult year. And it's heartbreaking for families because we will have a mom, driving in from New Jersey because her son's roommate called and said, listen, I probably should have been on the phone with you like 3 weeks ago, but he's talking about stuff that is just like way off the hook. In the beginning, we thought it was because he was using substances a little bit more, and I probably shouldn't be telling you this. But now he's talking about things that he fears that, we're trying to kill him. And we will get half a dozen or more of those calls or contacts from young adults who are experiencing a psychotic break. Sometimes it can be precipitated by drug use. Other times it's just kind of this natural kind of expression of kind of a latent predisposition to psychosis. Warning signs of suicide, and again, I am not, and by the way, these slides are part of what we set out as Carruth, but I'm also one of the folks who will let you know I really am less inclined for staff to feel that they've learned the warning signs, and I'll tell you why here in just a second. But again, these are things that you would not assume to be different than your own personal experience. We've already talked about signs of distress, but hopelessness and helplessness and the sense of alienation, especially in young adults, are very, very common facets associated with depression and acute suicidality. The more that alienation and then an inability to see hope in the future dominates a person's experience, either acutely or on a prevailing basis, has a lot to do with the risk for suicide. And then again, if they had poor coping skills and don't necessarily feel that they have access to health services, those are other problems as well. But feeling that things are out of control, we will often hear, and one of the questions that I was asked to field was, how do you handle a situation where it's an imminent risk to oneself? But often, you may hear it in terms of social media that comes your way, either at the hands of another student or someone that you're talking to, about this is what they left on their Twitter feed, or this is what they texted to another student. And anytime somebody's expressing a thought of harming themselves, it's a big concern. Just yesterday, and I wish I could remember which academic department it was, it might have been chemistry. Valerie Lastinger had been in contact with a student who was a vet here on campus and was facing an academic matter. And he stated several times, as this was being disclosed to him, that he was going to blow his head off. So very appropriately, they were in touch with us. This is one of the situations where it would be best for them to be in touch with the police first, but that's okay. It's a public safety issue, but for us to be in the loop, we'll take care of those other things as well. And the neat resolution, this man was very distressed over the news he was receiving. UPD arrived, and they try to get to the scene as soon as possible. And sometimes even if you anticipate that a conversation like this could result in agitation, you can call us, you can call UPD, and actually have folks not like in the room, but standing by in case they feel that the situation could escalate. Very distressed individual. He was in fact threatening that he was going to take his life. And I think any time a vet is involved, people want to know if there's access to weapons or trained use of weapons, and those are legitimate questions. But to make a long story short, after the conversation was held and he was still very distressed, they let him know that UPD was here. Would you be willing or inclined to go see a counselor at the counseling center? And if you are intimating that you're going to take your life, there are a few other questions we need to ask because we need to keep you safe. He backed away from that, not because UPD was there, but he realized that what he was saying was causing a great sense of alarm in terms of he's actually going to take his life. UPD talked to the young man. They took him out to get something to eat. The situation markedly de-escalated. He came in with 2 officers within 45 minutes of talking with one of our counselors, had a very meaningful and supportive discussion. Was he still distressed about the academic outcome? He most certainly was. But he also knew that he had a friend in the university police department, and that the manner in which he presented himself was received seriously, but not in a way that created fear or just this reactive emotion on the part of the people who were handling the situation. And he felt that he was handled, or he was addressed very fairly. So it's just a remarkable outcome. But the whole reason I share this with you is that anytime you are in personal receipt of information about threats to self or others, it's very important to take that seriously. Risk factors. If there's concurrent substance abuse or dependence, again, the idea of social alienation, lack of support systems. If there's been a recent loss, and in the case of this young man yesterday, the loss was perhaps being severed from his academic program. Financial problems, conduct problems, times of transition. And this is true especially for our students, whether they're first generation or whether they're coming to us from Nepal. They're academically inclined, they're excited, and they underestimate the degree to which their acculturation or their just adaptation to a new environment really creates greater stress for them. Protective factors. The opposite of these things are true. If they are connected to family, friends, peers, even at a distance, that's hugely important. If they have demonstrated problem-solving capabilities, if they do have a self-esteem that's not only tied to academic performance, but they see other features about themselves that are enduring or abiding. The availability and their choice to access support services, either in the present or past tense, also is a good protective factor. Their involvement in other activities, again, something that would kind of broaden their sense of self rather just in their reaction to an untoward circumstance. Be able to look in a future direction, and then aspects of spiritual beliefs or values that they hold dear. That again wouldn't just prevent them from killing themselves, but again are reasons to live. Next issue, and I know we're going through this relatively quickly, but talking to students. And again, one of the reasons I shared with you that I'm not a big fan of the warning signs and stuff is people will inevitably ask about do's and don'ts. And the one thing I'll share with you, and probably some of you in this room have heard me mention this before, please don't underestimate even the most cursory of relationships that you've established with a student. Often when there is a crisis, as I said, people with the greatest of intentions want to get the help they can to their student, but they so quickly back away from their own relevance and interaction that it can create a real difficult experience for the student. If they came in to see you about a problem, and then you're quickly reaching for your phone and saying, well, this is out of my range of expertise, I'm going to call so-and-so, the student may feel, well, all right, we may need to get to that, I get that, but I need to talk with you about this. And again, I've seen very well-intended faculty and staff and even other students back so quickly away because they don't want to say the wrong thing. You know, I understand, I truly do. But that's why the emphasis I'm going to place on you more than these do's and don'ts is don't underestimate the relevance of your relationship with a student, or more broadly, a peer or a family member. The fact that you're literally with them is of huge importance. And would you benefit from concurrent support and consultation? Absolutely. But I see so many folks abandon what is otherwise a very rich relationship, or even has a level of meaning that is beyond what they can understand because the student basically came to see you. So the do's are communicate your willingness to listen. Be less of a problem solver in that situation. Also, don't discount the things that they are saying. Many of you are parents, and it's amazing to me when our kids were young, we would want to kind of normalize the circumstances of what they're going through. And so my 8-year-old daughter could come to me and say, oh, but Dad, you know, he pushed me down. And I could say, you know, honey, I know that's really upsetting that he did, but, you know, I've seen that's kind of his style. He's really aggressive, and he tends to kind of get in people's way and those types of things. So I'm trying to, in my 8-year-old, let her know that these types of things can happen. Fast forward, I'm talking to my 20-year-old daughter, and she tells me about an interaction with a friend. And I try to normalize the circumstance by saying, you know, Morgan, honey, I understand that, but you know, that's just the way your generation is. I am immediately discounting her experience because I'm still using the same techniques I did when she was 8 years old. With adolescents and adults, it's far more appropriate to kind of connect with them in the nature of their distress than trying to discount it, because that's not our intention. We're just trying to let them know maybe this isn't as bad as they thought. But parents will do this when they're in their 80s and their sons and daughters are in their 50s. You can still imagine conversations you have had with your parents where, you know, you're well into things, but you tell them about something, they'll say, that's just the way it goes, I don't know what to tell you. So it's one of these things that just continues on. On the do side, express empathy in whatever way is genuine. Don't parrot their statements. Don't overly indulge. I have therapeutic colleagues these days who are still so syrupy in their empathy that the students can see right through it. They just don't feel it genuine. They feel, I'm not talking to a therapist, what I expect. Of course, they're leaning forward and handing me a tissue and saying, oh, so tell me more about this. That sounds really, really bad. But be you. In whatever way what they're sharing with you connects with you, it's perfectly fine to say, you know, I actually have never heard of anything like that before, so I'm sorry you're going through that. That is hugely important. So that's kind of my very brief summary of the do's and don'ts, because again, I've shared my bias with you. I don't want you to worry about those specifics. Be genuine. Don't underestimate the value of being connected. How to refer, let them know you care and you want to help. That's the best transition that you can make at any point in this discussion, is to be genuine about your desire to help them, and then encourage them or ask them, have you ever considered going to see somebody? Is there something in the midst of what you're going through right now that I can help you with? You're really exploring their ability to receive help in that regard. Again, ask about, if it gets to this point, by the way, this is again something I would share with you, you are not bearing the responsibility of doing a risk assessment. But if somebody has shared with you that they are at imminent risk, if a student comes in and says, oh man, I don't even know where to start, but, and I'm not even sure if you're the right person for me to tell this to, but I was up all night, and I guess it's all I can do to keep from jumping over the Westover, off the Westover Bridge. And if you were to see that's, oh my gosh. And you can say, listen, I'm sure it's really difficult for you to talk with me about it, but I'm so glad that we can. I've got a couple questions for you, if you don't mind, because I want to try to help you kind of deal with this. How long has this been going on? Have you made an attempt in the past? Is this a familiar feeling for you? Because one of the things that we'll do in a risk assessment when someone's expressed that is we do want to know how familiar are these thoughts and have they taken actions in the past. Again, this is not your responsibility to ask, but if you're ever presented with that opportunity, the question about previous situations that have elicited those types of thoughts or experiences, it may be an opportunity for them to talk with you about the fact that they did attempt just 2 weeks ago. And that would be crucial information. Other things have to do with their access to means and whether or not, again, they have in fact attempted in the past. But again, if you're ever at a point in a conversation, rather than just freaking out, which we would all be freaking out, how you can connect with their expression of whether this is recent, how imminent it might be, do they have a plan? And you would be amazed that questions you have never asked before and feel very inappropriate to ask because they're way too personal. The fact that the student is distressed in just opening in front of you, they feel relieved often that somebody is directly asking those questions. And one of the slides before, and this one emphasizes it again, if it appears that the student is suicidal, ask the gall darn question. And I can tell you a soft area of this, and this is not a rebuke, but a lot of people would say, have you had thoughts of harming yourself? And that's not a bad question. But as a brief aside, self-injurious behavior can be non-suicidal self-injurious behavior. Many of you will encounter and have had experiences with students who cut or burn or punch themselves. And that is a concern, okay? But those behaviors are not necessarily suicidal gestures in any way. And I don't expect any of you to discern the difference between superficial cuts on an arm and evidence of lacerations, because I can tell you that superficial cuts on the arm could also be suicide gestures as well. But the point I was going to make is that I encourage people to ask directly, do you have thoughts of taking your life? Is a very appropriate. And again, people are sometimes you've never had to ask that question, so it feels too stark, too abrupt, too intrusive. But I'm here to essentially remind you that the myth that talking about suicide increases the likelihood is just that, it's a myth. Discussing suicide openly with somebody is not going to increase their likelihood. And number two, you may be surprised at how inviting that question might be to somebody who's really reaching out for help, or who may not be reaching, but just in such a state of confound that having somebody directly inquire is a great relief to them. Ask, be direct, ask if they have a plan, do they have means to carry it out. Again, just to let you know, asking these questions does not increase that person. Seek help immediately. This is sometimes difficult. At our center, we will not leave a student alone. I'll let them know. Tom, I really appreciate it. We've had a chance to kind of talk about this as we agreed. It's okay with you that I contact your mom, and if you prefer that, you can sit with somebody else to talk about some of these things while I make that contact. I'm going to ask a colleague to come into the room So I may excuse myself for 5 or 10 seconds to look at a colleague and have them come in and sit with Tom while I go out and make those calls. You may not always have that luxury. And I'm not saying, again, that it's your responsibility to keep them safe. But once you've identified that, it's not even so much a responsibility to make sure that the environment is secure and they don't run away. Think about this. If you've just disclosed something monumental that you weren't even sure you were going to disclose to somebody, and then they leave and they're gone for 7 or 10 minutes to do whatever they're doing, you can sit there in your own thoughts and think, oh man, I definitely shouldn't have told them. Now everything's going to spiral. Now they're going to call my mom. All these private, sudden thoughts about the sequelae of their disclosure is really burdening them. And it may be that they trust you and are very thankful for you helping them, but your absence gives them access to all this immediate rush of, oh my God, what's going to happen? And that's why you don't leave a student alone. It has less to do with you're responsible so that they don't run. It's just be aware of the intrapsychic experience of having disclosed this information. Yes?
Can you drive them there?
Absolutely. Yeah. And in fact, it's neat. We'll get calls and folks will say, I just want to let you know, Al, or our clinic director, or our client, or our staff on call. You call in and say, I've had you need to be with the presence of the student. You say, I'm so and so from this department, and I'm bringing over a student. This is their name, and I can tell you more about it when we get there. I just want to let you know we're on our way. We love those types of calls, and we get them quite frequently from people who are about to come or considering come, or people who are literally in the parking lot. But it helps us mobilize the staff too to make sure that we can handle those issues. But yeah, if you're at a place with your student and they're willing to do this with you, it's a great idea. Drive them on over. Those warm handoffs are very much accepted. And the other thing about that is that when you come there with the student, the therapist will come out and they'll introduce themselves to the student, and you'll say, I'm so-and-so from this department. And then the therapist will ask the client, it sounds like there's a good call for you to come on over. Are you comfortable talking with me individually, or would you like, Dr. So-and-so to join us? It's the student's call. And it could very well be that if the student just goes back with the therapist, another therapist might come out and say, I understand that you brought so-and-so today. Do you mind giving us some background information on that? But it really is up to you as well, because you might have brought them over and you have to leave. And again, we understand that as well. You can say, please leave my number in case somebody needs to call me. Because you guys can share anything you want with us. Anything. Under FERPA, if there's a concern that's a health and safety concern, you can speak with anyone about that. Okay? And again, that's another issue that we won't necessarily get into great detail unless you have questions about it. A lot of folks feel very hamstrung by HIPAA and FERPA. Well, the truth of the matter is, if you are addressing an issue of safety and welfare under FERPA, that information can be discussed without question. The latitude is to allow that. HIPAA is more binding on us as professionals who have developed a consensual relationship with our clients, but even HIPAA allows me to speak with another healthcare provider to advance treatment. In a psychiatric field, it certainly is beneficial to my client to request that I do that. But HIPAA allows disclosure between healthcare providers about treatment, and if there is an issue of imminent risk to that person or another, again, it's within the full range. I apologize if I took you too far afield of that. Again, the Carruth Center is open, and we talked about our hours before. Escorting them will provide support and assurance for you that they meet with a counselor. That's all fine. University Police Department and the Emergency Department are dispositions that are routinely made. These are the last two slides, and we'll go into some other examples. I wanted people to be aware of the fact that there's a behavioral intervention team. And that's the generic term that's used. Our team here is called the CARE team, and that is their URL. They were just put into play last February, and they are chaired by Kim Mosby from Student Life. Stacy Vanderbilt from Student Conduct is also a member, as is Tian Hawkins, who is our clinical director at the center. Trish Sandetta from Residence Life, Joe Seaman from Academic Affairs, Sherry from the UPD, and then Allison Hayes is their care team manager. they are exactly doing what they said they did. Big teams, behavioral intervention teams, became far more popular after the shootings in Virginia Tech. They wanted to develop an integrated body that was objective, that really advocated for the autonomy of the student and concurrently addressed the safety and the academic concerns brought about by any number of different presentations that you might see. And so if you have a concern, you can do it online, you can put in a referral form, or you can call. And they literally staff all of those concerns every Thursday, or if it's a more pressing concern, they'll staff it immediately. They'll call an emergency team, they'll talk about what needs to be done, and since you've got UPD, you've got student conduct, you've got residence life, you've got academic affairs, these people come together very quickly and address how to handle that situation. Now, sometimes the Carruth Center is directly involved, because it could be a client with whom we have a relationship, and while we can't let on that that's the case, we certainly can be a repository to see that individual. They also figure out with who the referral source is, whether that person may be more intimately involved in these activities. And they don't tell you what you have to do. They don't say, well, we're not going to handle that one, Lori, this one is on your own. They're very, very supportive, but they also offer immediate consultation. And as you can imagine, with a lot of the student situations that we face, it's not just a question of whether the mental health is a question, which it very well could be. There are other behavioral characteristics, or there are certain aspects of how the student confronted this particular instructor. And now the issue is not just the student, but the instructor's safety. And so the care team is there to look at all these different permutations and make assignments and work with you to address on a campus-wide basis how best to handle the situation. So again, it's very common for them to be at other universities. Ours is kind of in its nascence, but it's doing a remarkable job. And then the last thing I'll share with you essentially is this. Cognito is this online program that we've had for the last 3 years. We have been a part of the Garrett Lee Smith Suicide Prevention Grant, and that grant now turned for us this past February. One of the things it allowed us to do is bring Cognito, which is a very expensive protocol, and it's available for all of you as staff, and it will be available up until we think either March or April of this year. So if any of you have an interest in just learning or running through a virtual scenario of how to talk with a student who may present with mental health concerns, it's a 30 to 45 minute interactive role play that has received marked and beneficial reviews from a variety like NAMI and the JED Foundation really endorsed this product. And we'll have it just for a little bit longer. You can also get the segments on a per trial basis as well. But we have a segment available for faculty and staff, for LGBTQ, for vets, for students. And again, notably, out of all the universities, we received recognition for having the most number of faculty and students sign up for them. But it's a paltry percentage of students and faculty who have actually chosen to go through this. But if any of you have a personal interest just in digging around a little bit or just going through one of the modules, I would strongly encourage you to do so. It's a very good, again, virtual skill development program. It's called Cognito. It's available on the Carruth website under resources. So I know I've rushed through a lot of information. I hope it wasn't too rushed, but part of it was to really give you an opportunity with all that background to share with me either questions or scenarios that you've experienced where by going through them we might inform kind of the collective understanding of how we address some of these circumstances. So if there are questions either about the materials presented or scenarios you'd like to discuss, I'd love to chat with you about them. Yes, sir?
Just a quick clarification I'd like to ask you about.
Yes.
I have a question. So just so I'm clear, the services that Carruth provides are for students, not for staff and faculty?
That's correct.
Okay. So I understand that one of the needs that comes up commonly is a student who's being cared for back home,
right,
and needs a prescription refill,
right,
and it's too far to drive, and they come and say, can I get a short-term refill until I can go back home and get it removed?
correct.
Is that something that you can help with?
Yes, we can help with that, and it's a qualified yes. It depends what type of scheduled medication. So most commonly, if a student is coming from New Jersey and they've lapsed in the prescription of, excuse me, I think my mic just went dead.
I'll go to the other one. By law, we can't do that. They can come in and talk with psychiatrists, but we're not in a position, and it's not ethical and it's not legal for us to extend a prescription to cover under those circumstances. So there are going to be certain scheduled medications where a student calling in, understandably, to maintain a medical regimen is one that we can't directly assist them on. We can make sure that they get in touch with their physician as quickly as possible. That individual will have to go back to New Jersey on that scheduled medication to actually receive it. And this will also vary from provider to provider, not in terms of the ethical consideration, but there may be a student, let's say, who is on an SSRI, Zoloft, for example, and they've lapsed, and they've been out for 10 days, and they're starting to have side effects. And for whatever reason, the best option in that situation would be the physician back at home to write them a prescription, which they can do over the phone and have it sent into the local pharmacy. But one of the permutations is the student who's now lapsed for 10 days actually had a prescription that extended for 3 months. And way back in May, when their physician in New Jersey said, when you get to West Virginia, I really want to establish care, their physician hasn't seen them for over 3 months. And they're reluctant, even if it's Zoloft, and I should say even if it's Zoloft, but if it's not a scheduled medication, they're going to say to that student, oh, I'm glad you called, I know you're in a difficult position, but quite frankly, I'm not inclined to prescribe for you over the phone. And if you are having side effects, these are things you might reasonably consult with somebody about and establish your care going forward. Then it's not going to kill you. You may be uncomfortable, but I can understand why that physician is not going to prescribe. So we try to work with our students in all circumstances. We will never over the phone say, don't come in, or we won't talk with you. We will work effectively with them to resolve the problem. It's just that we may not be able to do what they and their parents want us to do as readily, either because it's a scheduled medication or the nature of the care invokes other important information that the prescriber would ultimately want to have to effectively prescribe that medication. Any other questions about that?
Do we have service to help students who can't afford their medication?
There are, and it's great. Health Right is a name that many of you may be familiar with, and a lot of the pharmaceutical companies will also have indigent care type plans that they can arrange. Increasingly, well, it used to be, I'm not going to say in the good old days, but when I started at behavioral medicine in the early 90s, the pharmaceutical reps would come through with samples, and the stockpile of samples was unbelievable. Those days are gone, and probably with good reason, but it used to be that used to be a wonderful repository for our residents and psychiatric staff to be able to use it. That's just really not the case anymore. But the number of pharmaceutical companies that do have special programs that allow students to get medication coverage, and then Health Right and other community services are excellent in terms of getting that medication available to indigent students.
So a lot of our problems are not as serious as suicide, or we have had students who've been concerned about risk to others, but often after, we get the student to a point where they're going to Carruth, there's sort of a fallout in the background, and also there's other things to attend to. So for instance, if one of our students had a car accident and was in the emergency department and comatose, and they were supposed to be in Mike Schaller's class, I would go to Mike and I'd say, Jane is not going to be able to make it to class. Look, this is what's happened, and we'll keep you informed kind of thing. With these kinds of issues, how do we deal with fallout? How do we deal with the other students in the class? I mean, what privacy do we need to keep for the student? What should we keep? How do we communicate these issues?
So much of that is discretionary,
Okay.
and because each situation differs. But that's a great scenario, Lisa. And so let's say something untoward has befallen a student, either in terms of an accident or a health issue, some problem at home, and you're familiar with it in part. and the student themselves is not there to address those issues more directly. Always, the best opportunity is to have somebody from your department who has a relationship with that student, if the student is capable of being reached, to understand what are the limits of their interests or their opportunities. Sometimes they are incapacitated, either physically or psychologically, or the nature of their treatment has got them otherwise occupied, which is really appropriate. You can talk with their parents as well. You are given great latitude in terms of how you address those emergency contexts. What you don't know, and this is sometimes true, people find this out after the fact, and it's a rare number of cases, students not available to address this issue, and they are adults, and a contact is made to their emergency contact, but they're estranged from their family, or the family doesn't know the full volume of what you know, and it may be the first time that mom and dad is hearing about this. So it was a motor vehicle accident, but you're also aware that substances might have been involved. You really have to be clear within yourself how much information you would provide. But I go to this next piece because aside from the student themselves, their family, irregardless of the student's age, is often still a really good appropriate guide as to how much information they actually want to get out there and whom they want it to be released. The other thing you know that is concurrent with all this issue is depending on how the student was connected, what's out on social media may be way, way ahead of what people otherwise know. It is stunning how quickly students are either advancing actual information or disinformation in social media. And that's why in the old days it used to be that you control, and I don't want to use that word, but you would have direct influence over what information was released. That is a complete crapshoot right now. There are situations in which we were involved, which we assume that lots of information had been placed out on social media, and surprisingly, it was like crickets. And then we have other situations where we thought we held everything pretty close to the vest, and it was already out there. So it's really difficult. I think part of it is just being attentive to different sources that might have been accessed by the student and or their family, if you can, enlist their direct support in that. And then bottom line, and this is true, and it sounds too broad, but in some ways, just exercise your discretion. Do what you think advances what you assume to be the needs of the student, rather than concerning yourself too much about who would want to know. There's a lot of people who would want to know, and I understand that. But I think the more disciplined response is, no, I appreciate there are a lot of people who are concerned. We're still trying to get in touch with the family and learn a little bit more from the folks who are directly dealing with the student before we share more information. Is that understandable? Does that make sense to you? Because again, I don't want to put somebody off because of their questioning about that. But if I have information that I'm not exactly sure how this would serve the needs of the student or their family, well, as a counselor, I can't describe it anyhow. But if it's not a counseling, if I'm not duty bound to the confidentiality of the student, but it's a situation I've heard of, I'll be more circumspect with my disclosure unless I know more directly who's been in touch with the student or their family and what we want to disclose. But one of the real typical things about your scenario, Lisa, is that if a student is missing from a class, as you can imagine, the number of students, roommates, and instructors who are really concerned because this is unusual. This is really difficult. The roommate that goes home and finds that the roommate is not appearing for 12 to 36 hours, that's a scary deal. So we're very sensitive to the degree to which the absence of information, it just doesn't cause worry or suspicion, but in some of these cases it's so unusual that it causes fear and concern. And we don't want people unnecessarily harboring, worst case images when that simple disclosure could avoid some. But you're granted far more latitude in that than you would anticipate. And every case is different. But what I will tell you is that consult with us. Talk with your academic colleagues. We get a call into the Carruth Center, and especially Tiana, clinical director, myself, and some of our more senior psychologists, have been down these roads, and everyone is different, even for us. But we can kind of share our institutional knowledge and try to develop a plan or approach that people can have some peace with. Other questions, other observations, other scenarios that you've encountered where you've had questions?
Thank you. That's a lot of good information in that. So this will be available to our colleagues. So we can, we'll figure out best ways to get the information out there, rely on the chairs to take it to the departments, center directors, really amplify the effect of your time.
No, I appreciate the invitation, and again, for me, I'm just in constant communication with you about events like this or opportunities that you see for us to be a benefit to you, or for you to give us information about our services. We're very open to that.
One thing is we were looking at the list of workshops that would be really intriguing would be to make sure these hit our info station outside of our office, just as a good point of traffic and awareness. Yeah, we'll make sure.
We update them from time to time. It's not uncommon for folks in certain departments to call us and say, hey, Al, we're in the next set of workshops coming out. And if we know that there's an interest, we'll get them out to you.
Great.
Thank you.
Thank you.
I was telling Nicole on my way, and I asked if she had been outside lately, because this was my first opportunity to put out canvas. It's beautiful.
That's great.
Oh, it is. It is remarkable. So hopefully you guys enjoy it.
It's warmer out there than here.
Yeah.
It's popping up for coffee.